Good evening, everyone. First, I want to thank Dr. Muhammad Al-Amari for his organization of this conference. Very excellent and successful as usual. And thank you, Spire, also for a kind invitation today to moderate the session with my dear friend, Francesco Bicchi. I know everyone knows him, but he is a retina and uveitis specialist in Cleveland Clinic, Abu Dhabi. A lot of publication, big fan of imaging. He has a lot of experience. So now we're going to share together some questions and try to answer it together. So Francesco, the floor is yours now.
Thank you very much, Hamid. Good evening, everyone. Thank you for having me here. So we have, Hamid and I came out with these 7 questions that we would like to discuss in the next half an hour. We're going to start with the first one, which is the management of subretinal hemorrhage. Should we start with surgery or anti-VEGF? So I'm going to spoil straight away. There is no right or wrong answer here. In the past 5-6 years, there's been a lot of interest in subretinal and intravitreal TPA, the activator of the plasminogen. And there's been a lot of studies about this. So I'm going to start with a case. This is a 77-year-old white male. 4 years prior, you see they are not great pictures because they're old, but you can see in the left there is a big scar coming from an old hemorrhage, probably, or a deciform scar. Now, here is the patient coming to us. The patient is complaining of a loss of vision in the right eye. You can see straight away there is subretinal hemorrhage. From the color of it, probably sub-RPE hemorrhage because it's very dark. And you can see here there is possibly some CNV that we can detect on fluorescein angiography. So what should we do at this point? We have 2 options, basically. We can take the patient to the OR and or take the injection through a series of anti-VEGF injection. Well, I'm going to tell you straight away, my choice was dictated by the left eye in this case, because the patient is monocular. He has a big scar in the other eye, and he deserves to get rid of this hemorrhage straight away. So I took the patient to the OR. But in that case, again, we don't have clear guidelines. Sometimes we do gas displacement with intravitreal TPA, sometimes subretinal TPA. Sometimes we don't use TPA at all. And sometimes at the end, we do an anti-VEGF injection. Well, what I did for this patient was PPV, TPA, subretinal, and SF6 displacement. And then I injected the intravitreal anti-VEGF at 1 month. And as you can see here, I injected 3 more injections. And the patient, at the end, in 1 year, you can see the patient is 20/30. There is an area of atrophy. There is a small scar here, and he's hanging on these small photoreceptors here. But the patient is indeed 20/30. So I don't know about you. I'm not going to give you the right or wrong answer. My decision here was dictated by the fact that the patient was actually monocular. But so I took the patient to the OR straight away. But I have other patients that actually are having a lot of benefit from a series of intravitreal anti-VEGF injections without the need for gas. There was at the Academy last year, there was a big debate with Dan Martin, if the patient should just go for anti-VEGF or for gas displacement. And again, they couldn't come out with the right or wrong answer. So anti-VEGF is indeed paramount, but to add or not surgery and gas displacement is up to you, and you have to read the patient in such cases. Anyway, OCT and OCTA are very, very useful in such cases to be able to identify the choroidal neovascularization, sometimes the rip in the RPE that is causing the bleeding. So moving on to the second question, the bilateral treatment.
Yeah, Francesco, thank you so much. Just thank you for highlighting this. As you mentioned, there is no clear guidelines, but the most important, as you mentioned, you have 2 things. You have to differentiate between the sub-RPE and subretinal, because you cannot leave the subretinal more time. You have to intervene early and not wait a lot because it's more toxic. And also as you mentioned, you don't wait too much. And for the TPA, there a bit about the concentration of the TBA, because there is some literature about the toxicity of TBA if you injected subretinal. So I think what dose you use, but I believe 25 microgram is good for subretinal.
Yeah.
If you go for intravitreal, you can increase the bit, but don't increase the much. Another thing, if you use TBA, you have to take care of the patient, because we know the hemorrhagic side effect of this injection. So you have to consult the intermittent if the patient is anticoagulant. Better to stop it before that. So otherwise, as you mentioned, it's not a clear guidelines, but the most important thing is to interfere early if you have dense hemorrhage. Would take time, especially if subretinal.
And actually, Hamid, you brought up a very good point, which brings us to the second question, because whatever we inject inside the eye, it goes systemically. So as you say, TPA, we have to be careful because it goes into the system, and same thing for anti-VEGF. So the second question we wanted to discuss together, Ahmed and I, is should we do bilateral injection of anti-VEGF or not? Well, it's pretty straightforward. There's pros and cons. The pros is, especially for our patients population here, when we think about DME, we have tons, I'm sure, Hamid, you have thousands of patients who have bilateral disease. And such patient, it's a burden for them to come for injection and then come again a few days later. So what do you do in such cases, for example? Do you do bilateral on the same day?
Yeah, I think it was, we can do that before, but I think I try to be, if the patient, in special case, I can do bilateral. If the patient is coming from far or handicapped or wheelchair, it's difficult to him, and there's a bilateral disease, significant disease, I think you can give that and consent the patient. But in the normal basic life, I inject not bilateral. Usually I go unilateral only.
Okay. I have to say, I do bilateral if I can. If the insurance allows me. I know, as you can see on the right side of the screen, I know there is a risk if you inject two eyes at the same time of an increase of anti-VEGF going systemically. And of course, the very low risk of endophthalmitis, you're basically multiplying it by doing bilateral. But at the same time, my patients sometimes they do injection and they come back complaining of the irritation, which is not the injection, it's the povidone probably, or sometimes a xylocaine jelly. And so they're a bit reluctant maybe to do the second eye. So you also have to read the patient sometimes, the mentality of the patient.
Exactly.
Important. So again, there's no right or wrong answer here. Hamid and I, we do different things, but our patients' populations are benefiting anyway from anti-VEGF treatment in such cases. So this is a difficult one. And what are we doing differently in this COVID time and in post-COVID time? So again, as I told you, I tend to do bilateral injection, and COVID pushed me to do even more, to push the patient even for more, because you want to minimize the patients coming into the hospital. And you also want to, maybe the treatment regimen, we'll discuss it later, but we changed, at least I don't know about you, Hamid, but I changed the way I practice slightly. I tend to use drugs that work a bit more. I tend to prefer regimens that have the patient come to the hospital a bit less. I don't know about you. What did you do?
I agree. I do agree with you. Yes, for this kind, we need to minimize the number of visits. So I agree with you. Yes, we have to, the treatment regimen, we should follow some treatment regimen that help us to extend the treatment. So I agree with you.
And I remember after the lockdown and the pandemic, I had lots of patients who lost so many lines of letters because they couldn't come to the hospital. So in such patients, I was more aggressive than in other cases in treating DME and especially wet AMD. And there's one nice thing. There's a nice paper that I wanted actually to bring the audience attention onto. This was published in the American Journal of Ophthalmology. So now, it wasn't happening before. I don't know about you, Ahmed, but before COVID, I was not having my injection patient wear a mask. Honestly, me wasn't prefer practice.
The surgeon should wear the mask, and you follow the silent technique or no talking technique and
Yeah,
during the injection.
exactly, exactly. But now we have patients that do actually wear masks for the time.
Yeah,
So this study looked at the flora of the bacterial flora inside the eye in patients wearing, as you can see, a normal surgical mask, loose fitting, a surgical mask with a tighten around the nose, a surgical mask with the tape around the nose, or an N95, or even a cloth mask. And it's very, very interesting. So when there's the no talking scenario, which is what we try to apply all the time, you can see that a tight mask with tape, even a surgical mask, reduces the flora inside the eye. And thus we hope it's going to reduce even more the chances of having endophthalmitis. And especially an N95 as well, but they're more or less at the same values. In the speech scenario, so let's say the patient starts talking, again, a tight mask with tape and an N95, they decrease the chance of increasing the bacterial flora. So I think this is something to keep in mind in this area particularly, because the patient is already having a mask on, so we can ask our nurses or whoever is preparing the injection to tape the mask. What do you think about it?
Yeah, that's very, very important message, because as you see in this nice article, yeah, tight mask with tape or N95 mask, you have to do it. So you will avoid increase the bacterial growth during the, the speech. So I totally agree. Thank you for bringing this article. I think it's helpful for all of us, because I know in some clinic, busy clinic, they might be, don't strict enough to tape or have a tight mask with tape. You just go with normal. But, something happened. We don't want this kind of. So thank you. I think it's very important message here.
Yeah, it is. It was a very, very nice article to read during the COVID time. Yeah. And what about antibiotics? Now we're talking about the flora inside the eye. So does it make sense to use antibiotics? So personally, I think most of us are aware with all these data that come from different studies. You can see in green, there's patients who did not receive any antibiotics after injection. And in blue, they did receive antibiotics after injection. And you can see the difference in the percentage of patients developing of endophthalmitis. So paradoxically, patients who are getting antibiotics after injection, they are developing more endophthalmitis. Why is that? Well, probably because you're creating a bit of resistance, because these patients are mostly getting they're getting an injection every month, and sometimes they're getting one every 5-6 weeks. So if they keep using for a week antibiotics, you get resistance, right, Ahmed?
Yeah, and also this patient is coming monthly, so they will take a 1 week every month course of antibiotic. Usually, most of the people prescribe a broad spectrum or fourth generation. So as you mentioned, it's very important because it decreases the sensitivity. And I just to highlight, it's the same for oral antibiotic. Usually, if you go any doctor, internal medicine, he doesn't recommend to use antibiotic frequently unless it's really used because it affects the sensitivity or the resistance in the future. So we should look at this angle, and not overuse or abuse the antibiotic in such a minor thing. What I'm doing actually to avoid when you inject this, I pull the conjunctiva a bit, so there will no direct continuation. So the conjunctiva will retract and will cover the sclerotomy site, which is very small, 30 gauge. But if you want to be more on the safe side, you can do that. But as you mentioned, there is no rule, and also the most important, I think, there is Bivudine 5% pre the injection, the most important. Yeah,
exactly. Yeah. So in the next slide, which is here actually, so the use of povidone iodine is the most important thing to reduce the chances of endophthalmitis. But let me ask you something, Hamid. So we're talking about anti-VEGF. Let's just talk about implants. So if you have an implant and the gauge is bigger, of course, do you prescribe antibiotics or not?
You're talking about the like steroid.
Like steroid implant, yes.
Like steroid implant, yeah, I do that. Honestly, I do that.
Yeah, me too. Yeah, especially because it's not every month; it's every 4 months, or sometimes if you're lucky 6. So in that case, I do as well. Yeah, I'm glad we agree with this one. And talking again about COVID, about how it changed our practice. all the audience is aware that there are not just one way of treating our patients. You can try to optimize the treatment by managing the patient with a PRN approach. So the patient comes, you do an OCT, and then you decide on injection. You can do a monthly approach, or you can do the treat and extend approach. So there's pros and cons with everything, because we never want to undertreat the patient, whether you're talking about DME or especially AMD, but also you don't want to overtreat. Now, not just with the DME, but in AMD, they're talking about the importance sometimes of those CNV that are probably not exudating a lot, so they're maintaining the homeostasis of the outer retina. So I think it's important to discuss also the treatment regimens that we use. Now, just as a recap, the PRN treatment consists of the 3 loading dose, and then every month the patient comes and he can get an injection or not based on the OCT. So in this kind of population that we have here, I don't know about you, Hamed, I find that sometimes it's very helpful for my patient to see the OCT. So that's why some treat and extend sometimes is not my way to go in DME, because they want to see the water in the Shabakia and they like to look at the OCT, right?
Yeah, and
so you can justify an injection. You can show them the difference in the central retinal thickness. What do you think in such cases?
I think, yes, I think it's good to show the patient, but sometimes they have this advantage, because sometimes it's not going and you stuck, it's not improving. And we have this, and you switch and you do everything, it's still some fluid there. But usually, to educate the patient about what we are doing and why we are injecting, he will be accepting the treatment and the result also sometimes.
Yeah, and treat and extend is the other way to go. And I think it's very, very valid in AMD especially. I think it's something you have to discuss straight away with the patient, because the patient needs to understand. And the problem that I see the most with the treat and extend regimen is that there's no fixed regimen, basically. So the way I do it, I load the patient until it's completely dry, both subretinal and intraretinal, and then I start to extend. And if the fluid comes back, then I inject every time. And then if the fluid comes back, I go back to the normal interval. That's what you do as well, right?
Yeah, I think yes. Yeah.
So especially talking about AMD, the proactive treat and extend offers the more advantages. It reduces the number to come to the hospital, and it means retina completely dry, because now they were hearing a lot about this seesaw pattern when there's fluid coming and going. We never want that, right? So treat and extend is indeed something that makes more sense in AMD for me.
Yeah. And just to add one point here, since we're talking about the COVID and we want to reduce the appointment and the extend, I think the new generation drug coming with longer durability, I think this is what we are looking for nowadays. And this, I think, the trend now in all pharmaceutical company now, they are trying to make long-acting or more durable drug. So it will help us for this aim. If we extend also on this drug, it might last longer. So that's what we're looking for.
Yeah, absolutely. And I think we'll discuss it also at the end very briefly. Now, the real world evidence on DME. There was a beautiful editorial on on ophthalmology that was saying that what we actually see in randomized clinical trial is not real life, doesn't reflect real life, not all the time, because central retinal thickness sometimes is not the best biomarker, because our patients don't actually count every single letter. We don't base it on letters. We use 2040 or Snellen anyway. So I'm just going to show a case, a very quick DME case that shows that sometimes indeed it's the opposite, that clinical trials reflect the reality. This is a 44-year-old male, HbA1c is 9, 20/70 and 2100. And you can see here, there's intraretinal fluid and a lot of exudates and some pockets of subretinal fluid in the right. So I started with ranibizumab, and the patient after one didn't respond at all. It was over 2100 in both eyes now. and this is the change after one ranibizumab, so it's basically 0. I went again after 1 month exactly, and you can see still the vision is very bad, and the retina is actually getting worse. The thickness is much worse. So this is a case where I didn't wait for 3 loading doses of the same drug. I just shifted even before completing, and you see there's an improvement in the visual acuity, and there is less fluid in such case, and this is the change in central retinal thickness. So I just wanted to show this case to see that sometimes, even if I give a hard time to pharmaceutical reps saying that all the protocols that they show me, they don't represent my clinic, sometimes they do, like in such case, for example. What do you think?
Yeah, I think, yes, that's I want to ask you because you switch very early. So you are switching based on this study, or this is your normal routine? If you have
no,
not enough support.
I switched on based on frustration in this patient.
Okay, oh, yeah,
you know, it's a month. I've been waiting. I've done 1.
Yeah.
I've waited a month, done 2, and then at this point, nothing is happening. Why should a 3rd one make any difference?
But usually you switch after how many injections? Usually, in your practice?
Try, if there's a bit of response, both in the visual acuity and in central retinal thickness, even a tiny bit, I wait for at least 3 injections.
You still give it, okay,
yes,
good.
I still give it a 3rd one, but this was getting worse.
Yeah, sure.
That's why
this is this is an example that's getting worse, so you don't need to wait. I agree.
Yeah.
Yes.
And yes, this is reflected also in FRB, where patients who have less than 69 letters, they achieved better outcomes with aflibercept at 1 year, which is probably what I should have done with this patient in the first place. I should have started with the aflibercept, but in hindsight, you know. Can we look at clinical data to predict what the future may hold? So this is what Ahmed was talking about. We are aiming, all the pharmaceutical companies are aiming at new drugs that last longer. So I think the mistake that was done so far is that they actually aimed at creating molecules which are smaller. So like the last couple of molecules that came out, one was not approved. They are so small that they basically create inflammation of the self-inflammation of the blood vessels. That's the cases of vasculititis that we've seen with other molecules. We don't have a lot of data on the new Candela trial, but what they're doing, and I think Paolo is actually leading this one, they are using aflibercept 8 milligram instead of 2 milligram. So it's the same molecule, but in a bigger quantity. So, and the data are very, very reassuring. These are the safety outcomes, which are, there's no IOI, no retinal vasculitis, which is what we, at least I am sure you as well, Hamid, we are used to see 0 vasculitis or inflammation with the anti-VEGF that so far we had available. So that's just my opinion. I work with Pier Giorgio, who's an ocular immunologist, and he agrees as well that the smaller the molecule, the more your immune system reacts to it, and it more attacks basically the blood vessels in such case. What do you think?
Yeah, I think this new concentration of aflibercept, I think since it's supposed to last longer and more durable, but as you mentioned, we don't have still any initial results. But I believe we should wait because, as I mentioned, as we agreed that we need more durable drug, that if we follow the treat and the extent with a more durable drug, we might reach more like 16 weeks or even more in treat and extend matter. So that's a good thing that you have a new drug with a new concentration that lasts longer. But I'm waiting for the final result to see all the efficacy and safety. So that's a good point. Let's wait and see, as you mentioned. Yeah. So, but I totally agree with you.
Let me ask you a question. So if you have a pharmaceutical rep from a new pharmaceutical company that comes to you and asks, what do you want for your patient? You want a molecule that lasts longer so the patient gets less injection, or a stronger molecule, but that you have to do like monthly or bi-monthly? What's your answer? What do you need for your patient?
I think all of us need a long-acting drug, but at the same time, it should be efficient or effective and safe also. it's not the durability. Yeah, it's a trend, but we have to, at the end of the day, we need the efficacy and safety. So if they have the 3 in 1, it will be perfect.
And so, you know, they're also talking about this new depot that you can implant in the eye.
Yeah.
So are you more comfortable with the new molecule that they tell you lasts longer, or with the depot with the old molecule?
You're talking about the BDS, right? The pre-filled.
Yeah.
I think it's more aggressive, and honestly, I will not going to use it because I'm again we agreed about the reinfection, and we are going to refill it, and it will be have a rotation, and I don't know. I don't think. I think more durable drug for me. I will use it rather than the device, which you need surgery, and it's a bit complicated for the patient also, especially in our area. You know. That's my opinion. I don't know about you. I'm going to use it or not.
I agree. So I want to have new molecules, but molecules that are actually they have a safe side. They have a safety profile that I can count on, and finally we can increase the interval, even going more than treat and extend.
Sure.
So definitely that's something we should aim for. And you know, I was it's unfortunate that clinical trials don't reflect real life, because the side effects that we have seen with a couple of drugs that came out, they happened after clinical trials. So that's something that worries me a lot about new molecules coming out.
Yes, I think we reached the end now of our. You have more slides. That's it.
I'm just gonna thank you, actually.
Oh no, I am the one
and the audience for the attention.
No, thank you so much, Francisco. It was nice talking, one nice discussion, and I hope the attendees like the question and get some benefit. And as I mentioned, we all waiting for the new drug. I think the innovation in ophthalmology, especially injection, is dynamic. It's always evolving and evolving. But as we all agree that at the end of the day, we need to reach the perfect treatment, which is more durable, effective, and safe. So let's wait and see the coming. So thank you again, Francisco, for your time, and thank you also Bayer for the invitation, and also Muhammad Al-Amri for the giving us this time. And I hope to see you soon in real life, not in virtual anymore.
Yeah, exactly. Finally. Yes.
So I wish everyone have a good night, and stay safe, and bye-bye. See you.
Thank you very much, Ahmed. Thank you, everyone.
Thank you, everyone. Bye-bye. Take care. Bye-bye.